Hi there, everyone. Welcome back to Life in Motion. I'm your host, Grace Becker. I'm a licensed mental health therapist and an enthusiast of life. And today I'm joined by my friend, Josh Framke. Josh is do you prefer Joshua or Josh?
Either works. I
Okay.
I go by I go by
Okay.
anything in between.
All right. Government name, Joshua Framke. Uh, chill name, Josh. Or Framke. I suppose your friends call you just Framke a lot too, huh?
Yeah, that's how I'm most known, yeah.
Yeah. Okay. If you haven't picked up the vibes, we're very chill on this podcast. But
Mhm.
Josh is a counseling grad student at NDSU, and he was hoping to interview somebody in the mental health field for a class of his. And I was super honored because he reached out to me and he wanted to interview me for this. So it'll be a little bit of a different approach for this podcast, where normally I ask the questions to someone and discuss a topic with them. Josh will be doing most of the questions to me, and we'll just have a conversation about the different things that he brings up. He did send me the questions, and when I reviewed them, it's mostly just understanding like what it is to be a therapist or just to be a person in the medical or mental health field, different modalities, how to go about different certain circumstances that therapists can find themselves in, like when they get a client who is court mandated, or how to refer a client out, and different things like that. So yeah. Well, thanks for being on, Josh, and for reaching out to me. How are you
Well,
doing today?
I'm doing very well. Thank you for asking, and thank you for allowing me to conduct an interview. I know it's slightly different in podcast etiquette that the guest is interviewing the podcaster. So thank you
Yeah.
for letting this work out.
Yeah, of course. And like shout out to both Josh and my editor, because I was just on the phone with both of them for a long while trying to figure this out. Because I'm switching systems. So shout out to them. But yeah, do you want to just jump right into the questions?
We certainly can. I know how the questions are laid out is there's kind of a paragraph question, and how I'm reading it is there's multiple questions within it. So I'll read the whole thing, and then we can just break it down chunk by chunk if we need to, or if you just want to take over, whatever works. But I'll
Yeah.
read the first one then.
Okay, sounds good.
Um, what mental health service delivery modality do you primarily work in? What are the advantages and disadvantages of that modality? What is the difference between primary care, outpatient, partial treatment, inpatient, and integrated healthcare and aftercare? How do you go about the referral process if a client needs another level of care?
Oh my
Um,
gosh. Is this all
so
one question?
yeah, no, that is all labeled as one question. So I
Yeah.
suppose maybe we can take the very first part is what mental health service delivery modality do you primarily work in? How I interpret that is that like in person, telehealth, like group
Mm,
therapy, stuff like that. That's how I'm interpreting it. Maybe you have a different interpretation of it. And then in
right.
that modality that you're primarily doing, what are the advantages and disadvantages of it? So
Yeah, of
advantages of
course.
in person versus telehealth,
Yeah.
something like that.
Okay, yeah, absolutely. Well, so typically when I hear modality, I think of the type of intervention I'm using with clients. So that's things like
Mhm.
cognitive behavioral therapy, dialectical behavioral therapy, like different, like exposure therapy, different types of therapy. But it sounds like you're also interested in the population I work with and how I choose to provide those services. So I work primarily with individuals that are 18 or older. I prefer 18 or older, but I do work with some adolescents, right? I also work with couples and with families. So I kind of dabble in those three different populations, and I work with people of all that across all boards of like identity. I work with people who are in the LGBTQIA plus community. I work with like people of different cultural backgrounds. Like I said, I worked with families of all shapes and sizes, blended families, small families, big families. I've worked with couples who are like, again, a part of the LGBTQ community, or who are just, monogamous or non-monogamous. So I work with a range of clients. When it comes to how I provide services to them, majority of my people I see either over telehealth or in person. Occasionally, I will do like a phone call with some clients, but that's usually just for like a quick communication note, like just to
Mhm.
do a quick check-in. Or I even will give my phone coaching number out to some clients who are high risk or high need, and
Mhm.
they can text me at any time or day, like night, whatever time it is, any time or day, like I said, if they're going through a crisis. So I really work with all types. Yeah. Or would you like to know more about like different modalities in the sense of interventions that I use as well?
I mean, yeah, I'm definitely curious on that. Because yeah, it seems like how you interpreted modality was like the types of interventions, the theories that you're using behind it,
Yeah.
and I'm definitely interested in kind of maybe your orientation on that.
Right. Yeah. Okay. Well, I tend to dabble in a range of modalities, and I really like that you asked the population that I use first because for different populations, it will depend, right? So, for
Hmm.
example, ACT, which stands for the acceptance and commitment therapy, right? I usually use that with couples. Or family systems, I tend to use that with families more often. But things like DBT, dialectical behavioral therapy, CBT, cognitive behavioral therapy, like all NET, uh, which is narrative exposure therapy. I use all sorts of different ones. However, I will say that the most common modality that I use most of all is CBT, cognitive behavioral therapy, which CBT is a type of intervention that's used to help clients identify and change negative thoughts or patterns regarding their behaviors, the things that they're thinking, right? Have you ever heard like, oh, well, you seem to be ruminating on that, or you're overthinking, or you're just in your head
Hmm.
about it? Typically, CBT is used to help things like that, right? To challenge irrational thoughts or behaviors. Yeah, that's my
Yeah, I
favorite. That's my go-to.
Yep, I know CBT is one of the most well research backed ones. It's the one that, when you think of therapy nowadays, that's the one you think of. I mean, if you asked this 20 years ago, you'd be thinking of like, the armchair sofa therapist.
Right.
But
Yes.
CBT is the big one right now, and there's a lot of evidence to support it, which is good.
Mm-hmm.
But have you we'll zone in on this. Have you noticed anything that's kind of a disadvantage with that? Since I know you can pull up 1,000 studies that'll say this is the one, this is the best thing there is.
Yeah.
But maybe some things that aren't so great about it.
Right. Yeah. Well, and I know because you asked about advantages and disadvantages. So,
Mhm.
like you were saying, some advantages. One, CBT is one of the most researched and effective treatments for many diagnoses. It
Mhm.
also teaches practical skills to people. So it equips clients with coping strategies, problem solving techniques, ways to reframe those negative thoughts and behavior patterns, right? It's also very adaptable. I would say that you could use it comorbidly with a lot of other approaches like trauma or even DBT or exposure therapy, right? So it's very adaptable to populations and to other modalities. But there are also the disadvantages, right? So one disadvantage of CBT would be that it requires active participation. And this is one that I see probably most often as a disadvantage. So, because sometimes I'll get clients who will come in, right? Whether it's like a couple, maybe one person's more reluctant than the other, or I'll get a kid whose parent maybe kind of pushed them into therapy, right? The client needs to participate inside of therapy and also outside of therapy, right? They need to be willing to do the things they learn in therapy outside of therapy. Because the 1 hour per week that they meet with me is probably not going to do a whole lot for them if they're not using the skills outside of therapy.
Mhm.
Yeah. Another one would be that it's probably not suitable for severe cases alone. Like I said before, it's very helpful comorbid with a lot of other modalities, but because CBT and like the way it's designed and very like client centered, right? It may not be enough for certain individuals with severe mental health conditions that require more support, right? So sometimes then you
Mhm.
get into, okay, do we need long-term therapy? Do we need residential therapy? What kind of medication do we need, right? So a lot of times, sometimes it will need additional support rather than just
Hmm.
on its own. But yeah. So those are some
Yeah.
disadvantages that come with CBT for sure.
Thank you.
Yeah. Because I know you said you're a grad student, have you started a internship or practicum where you've used any modalities?
Um, so where I'm at in my program is
Yeah.
we've learned about them. We've learned like the basics skill of like, you know, kind of how to communicate and how to create a connection with a client. I haven't
Mm-hmm.
done any of the actual practicum or internship yet. My first prac will be in the fall of the
Yeah.
upcoming year. So
Okay.
I haven't done anything in the wild just yet. I'm excited
Yeah.
for it. I'm looking forward to it. But
Yeah.
um,
Do you
we've
know?
we've just
Oh, sorry. Go ahead. Go ahead.
yeah, no, I was just gonna say we've just been discussing. I know the theories class goes over, all the way back from Freud
Mm-hmm.
to modern times of like the different types
Mm-hmm.
of therapies that have evolved.
Mm-hmm.
But I was already pretty familiar with CBT because in undergrad I was a psych major,
Yeah,
and that's the one that gets talked about the most because it's the most well research backed.
for
It's
sure.
the scientific one. So
Mm-hmm. Mm-hmm.
um,
Yeah. Yes. I actually did. So for my grad school, for my program, we had to do our thesis, and we had to do a defense to like support it. And I
mhm.
did mine on CBT. So for sure, it is very a beloved modality in the mental health community.
Yes.
But yeah. Okay. And then your next question, you were talking about, I think grouped in that was with different types of care or treatment and the differences
Yeah,
between them.
how the question is phrased is what is the difference between primary care, outpatient, partial treatment, inpatient, and integrated healthcare and aftercare? So
Okay.
a lot
Buttload.
of different types of cares. Like
Yeah.
what are the differences between the styles of care,
Yeah.
I
Yeah. Well,
suppose?
yes, that's a good question. And for each of those options, it is going to be different because it's going to depend on the client, right? It's going to depend on their level of
Mhm.
need and what type of care they need. So the first one, primary care. So primary care is usually the first point of contact for general health needs. So this would be like going to your primary care doctor for your annual checkup, right? Just like see what's going
Mhm.
on. So that would be primary care. Outpatient care, and this is actually what I work in. So outpatient care is going to be medical or mental health services that are provided to a client without an overnight stay. So, for example, my clients, they come to me about once per week for 1 hour, and then they return back to their life afterwards, after their hour's up,
Mhm.
right? So that's outpatient care. They come and they go. Partial treatment, what you called, I also call this intensive outpatient care. So that's another name you might hear, partial treatment or intensive outpatient care. This is going to be kind of similar to the outpatient in the aspect that you come and you go. However, it's more intense, right? So with me, I see my clients for no more than an hour usually. But intensive treatment is structured where individuals can receive the therapy or the whatever care they need during the day and then return home at night. But they might go to this treatment, whether it's individual, group work, maybe 5 times a week, right? five
Mhm.
5 days out of the week, or they might go for an extended period in the day. So where my clients come for 1 hour, maybe they'll go to a treatment facility for 5 hours for 5 days and then return home at night. So that's going to be the intensive outpatient care or the partial treatment
Mhm.
care. The next one I think was it inpatient care?
Inpatient, yes.
Inpatient, yep. So, inpatient care, residential care, there's again different ways you could phrase it. That's going to be 24/7 care where individuals come and they stay in a hospital or they stay in a treatment facility for close monitoring. And the period of how long a person stays there is going to be dependent again on their needs as well as what the facility provides. So, I know that most hospitals won't hold a client for longer than a few days, typically, depending
Mhm.
on, again, what they're there for. Whereas where like I work, I'm connected to a residential treatment facility. I don't work in there, but I know we're connected to one. And they will work with clients for months sometimes, or weeks, right? Just again, depending what they need. So that's inpatient. And then the next one was integrated healthcare. So
Yes.
this is going to be a coordinated approach that combines a person's physical health, their mental health, their social services to treat the whole person. So it's really targeted to treat any like issues that a person is experiencing. So an example of this would be, say there's a person and say they're homeless, their mental health is horrible, their physical health is horrible. So they'll go to a doctor for their physical health, they'll come to a therapist for their mental health, and maybe they'll go to a social worker for their social needs, right? Like if they're homeless, to find housing, maybe if they don't have a job, if they're jobless, the social worker would help with that. And all of these providers would work together to support the person. And then what was the last one? The last
Aftercare.
aftercare. Okay. So aftercare is typically going to be the support and the treatment a person receives after a maybe that intensive outpatient program or a residential or even like a hospitalization, right? Say someone had a suicide attempt and they were hospitalized, but then they were released after 48 hours or whatever the regulation, the law is now in North Dakota. Then they might be referred out to someone like me, a therapist, for treatment afterwards, just to like continue to receive support. But it's just at a less intense level. So that can be aftercare. Aftercare can also look like maybe there was termination of services and a person, the provider, then reached out to the client just to follow up, right? To see like how things are going, to see if they need anything. But that will depend what that provider was doing with them. You know, like how sometimes you go to the doctor and they're like, okay, well, we'll follow up in 2 weeks. Or after a social worker maybe helps a person find a job or find a home, they might follow up again in like a month just to make sure things are going right. So that's aftercare.
Okay.
Hopefully does that answer that question of what they are, what the
Yes,
differences between them are?
I believe so. I mean, I learned a significant chunk there. I didn't
Oh,
know integrated healthcare or partial treatment, so I was familiar with primary, outpatient, and
yeah.
inpatient, but the other ones I was like, "Ooh, I'm learning here."
Yeah.
So,
Good. Maybe I'll
thank
come
you. I
teach a
appreciate
class.
it.
Yes, of course. Of course.
Yep.
Yeah.
And then the final part of this question was, how do you go about the referral process if a client needs another level of care?
Okay. Yeah. Um, that's a very good question. This is something that will depend on what
Mhm.
what you're referring the client out to, right? So say it's a client who is talking to me and they're like, "Yeah, I have this ache in my back and it really hurts." Then I'm going to say, "Okay, well, maybe go talk with your primary care doctor," right? And then I'll refer them out
Mhm.
like that way, like I'll say that, and then they'll hopefully make an appointment, and then I'll touch base with them maybe at their next appointment, just be like, hey, did you ever go to your primary for that concern? You know, because I want to rule out that it's not a medical issue first, and then I can address like, okay, well, have you ever thought about, your body really does hold a lot of your emotions. So if have you been feeling really anxious, like stressed, maybe angry, your body holds that in. So maybe then let's try some different ways of releasing that stress and that pressure and that anger. And maybe you'll notice that your body starts to feel better too. So that's kind
Mhm.
of how it would work in that sense. But there's also like a typical like good approach or structure for referral would be one to just assess the need for the referral, right? So evaluate what the
Mhm.
client requires. Typically, that's going to be asking yourself, okay, well, what services are beyond my scope of practice, right? Typically for
Mhm.
me, that's going to be things like med management, right? I don't work with meds. Certain specializations. So I don't really work a lot with kids, so I would refer them out. What's another area that I don't? Oh, people with eating disorders or
Yep.
substance abuse. I can do like very basics, right? Like talking about the very basics. But if they're looking for an intense, more specific approach to those things, I wouldn't feel comfortable with that. I think their money and their time would better be spent somewhere else with someone who's actually specialized in those areas. So then that's where I would refer them out. Then I would discuss the referral with the client, right? Explain to them the reason and the need to collaborate with another provider, address any concerns they may have. Some clients may be resistant. Have you ever heard of white coat syndrome?
I think I've heard of it, but I can't remember what it means off the top of my head.
You're good. So white coat syndrome typically is like people who are afraid of doctors because they wear white coats. And it's like, I'm scared of doctors, right? So I have some clients who are afraid to go to the doctors. So sometimes I'll help them, support them through that, right? I'll be like, okay, well, like, let's talk about that. You have a fear of doctors. What's going on? And then we'll talk about that, and hopefully that will aid them in getting that service. And then comes the point of obtaining consent from the client, right? So if this is something where I'm going to advocate for them and I'm going to communicate to another provider for them, then I need permission from my client. So typically I'll get an ROI, which stands for release of information. One time I talked about ROIs and my client was like, on investment. What? I was like, no. They worked in the financial world.
Similar, but
Yeah. I'm like, nope, that's not it. So I'll get that, and then I'll communicate with whoever they're wanting to get in touch with. So a lot of times when I do that, it'll be with, like I said, a social worker, a doctor, sometimes like a speech pathologist, somebody that will just get that ROI signed right away. So that way we can just communicate about how to best support the client. And then following that, then we'll like get them hooked up with the appropriate provider, the appropriate service. If necessary, sometimes I'll facilitate that referral. So one time I had a client who was below the age that I tend to prefer to work with, but I gave it a chance. I was like, yeah, let's try this out. And then I just kind of realized, you know what? I don't know if I am the best therapist for you. So after doing a few sessions with them, just to make sure that, I wasn't just in my own head about it and having a bias moment, I talked to them. I was like, you know what? Like, I think you'd be better suited with this therapist. And so when they connected with that other therapist, I was there for their first session together so that I could help create a smooth transition for them. So I could be like, okay, so like this is what they were seeing me for, right? And hopefully they feel a little bit more comfortable in that room with a new provider that they have to spill all their intimate secrets to again.
Yeah.
So I'll do that. And then, like I was saying before, follow up usually. Either with the client or with the provider who's giving them that treatment, be like, hey, just checking in. How are things going? Is there any like barriers or issues that need to be addressed? But if not, then that's usually when I cut it off, terminate. So yeah, do you have any like thoughts on that as well?
I'm trying to organize my thoughts as I'm taking everything in. I
good.
suppose the first question that kind of came to mind during it is, if a client really wanted to stick with you, I'm assuming you would still see them, but would you keep like kind of encouraging them that maybe you should seek elsewhere too, or
Yeah.
because I know you don't usually want to have two therapists because that does not go well.
Yeah.
Um,
Yeah, that's a great question. And so, gosh, our line of field, like our line of field of line, our line of field, is hugely based on the phrase "it depends." So
I've heard that so many times already, and yep.
yeah, like it really just does. But basically, in that situation that you asked, I would continue to work with the client because most of the time it's going to be like my own like insecurities or my own bias of like, am I doing a good job? Am I actually giving them what they need? But at the end of the day, the client really knows what's best for them. If they feel that they have good rapport with you, if they feel that they're getting what they need out of it, then sometimes that's just the reassurance the provider needs to know like, okay, I'm doing good. You said that you're getting what you need out of it. Like, let's keep working, and go with it. However, there are those few circumstances where maybe it's just, like I said earlier, not within the scope of my practice. I don't feel comfortable doing that. And if this is a serious issue, then you'll want to go somewhere else to get that taken care of. Fortunately, I've never had that. Most clients, when I tell them I can't, cure their depression with the antidepressants that I don't have, then I'll be like, go to your doctor for antidepressants. And then they'll go do that, right? Like I can't just magically make pills. But then I can help them with like the depression, right? And the thoughts and the behavior that goes with that.
Yeah.
So, yeah. Good question. Did you have any other questions about the referral process?
I don't think about the referral process. No, I can't think of anything off the top of my
Okay.
head. We can move on to what's labeled question number two, but what I think would be question number five, if you want. I don't know if there's something
Yeah.
you else you want to talk about real quick first, but
Yeah. What the next question was the court referred clients.
yes. Have you worked with court referred clients? What are some strategies for interfacing the legal system regarding court referred clients? Have you been aware of any recent legislative, government, and regulatory processes relevant to clinical mental health counseling or that have impacted your practice?
The first bit, have I ever worked with a court referred client? And what are some strategies for working with like the legal system regarding court referred clients, correct? That's like the first bit.
Yes.
Okay.
Yes.
Well, yes, I have. I have worked with clients who have been referred to therapy from the court. And I typically,
Hmm.
when they've been referred to me, it's for anger management because that's an area that I specialize in and that I have certifications for. I'm actually even
Hmm.
currently working on starting up an anger management group where I will be able to take court referred clients. But I have also worked with clients who were not ordered, but just strongly recommended to seek anger management from me or like parenting work, or just regular therapy in general. Sometimes like a lawyer or a social worker will say, you know what, I think this would be good for you to go do this. Even if they weren't mandated to do it. Some strategies will differ depending on the particular situation. But my number one recommendation to any therapist or provider will be to seek consultation from a supervisor, a colleague, or even if the agency has like a legal team for support if needed. As far as strategies when working with the legal system or a court referred client, I would always recommend seeking consultation first because it can be challenging, especially if it's your first time, right? Like me now, I'm comfortable with it, so I probably don't always need to go seek support. But it is a good idea too, if especially there's something new that is challenging. Otherwise, a good place to start with would just be to gather as much information as you can about the client, right? So why the client was referred out, what did they do? Like what were they referred out because they were abusing somebody for domestic violence? Were they referred out because they struggle with substance abuse? Like what's going on? What requirements do they need to meet? You know, sometimes courts will have certain things that they need to do or a certain time period that they need to meet. Sometimes like I've had to be able to communicate with like officers, like a parole officer, right? Have communication with them. So just figure out some of that information. The other thing that's really important is to make sure that the client and anyone involved in the case understands what the limits to confidentiality are in court mandated cases, because it's different when you get that involved.
Hmm.
So in court mandated cases, confidentiality is more complex than voluntary therapy. While the clients have privacy rights, there are expectations where the therapist must or may be required to share information with the legal system. So there may be something that the client shares with me, right? Like, oh, I started drinking again, right? We're an individual like who's voluntarily coming to me. If they're like, oh yeah, I had a drink the other day. I'm like, oh, cool. Like, where'd you go have a drink at? Right? Like there's no immediate concern for them. But if a client who's coming to me because they struggle with substance abuse and it resulted in like a domestic violence situation, who knows? And they told me that, well, I'm going to have to tell that to your parole officer. I'm going to have to tell this to
Hmm.
your lawyer, whoever. So making sure that they understand the limits of confidentiality, again, it's going to be different for the situation. So that would be another thing that I would do. And one thing that I think is also very important for therapists to do is to assess your own bias that you may have, because it can be very tricky in certain situations, right? These are still people, these are still clients who are seeking professional help. And if you're not able to
Hmm.
remain that professional like standard, like recognize that, because you can get some pretty difficult situations, right? Like you can get people who have hurt their family, their kids. You can get people who have, really done a lot of bad stuff. You can get people who have raped other people, right? Like it can get very serious. And if you think that you wouldn't be able to provide the care to someone with that, if that's like, again, a bias you have, do some self-reflection on that. Just, maintain detailed, objective case notes as well. Cases, they could be subpoenaed when they are court mandated. So avoiding to include unnecessary personal details, but also making sure that the details of your notes are clear of like what the client was doing and how they met the requirements that are expected of them. If that makes sense. But yeah.
Yeah.
What was the
Question that
Go ahead. Sorry, go ahead.
I was gonna do a quick kind of like sideline question.
Yeah, go for it.
You mentioned about like, acknowledging your own bias and maybe even challenging it. How do you go about doing that? If you are going to be working with a client that you know that you might have some bias with, like maybe it's something they've done, like court issued, how do you go about, preparing yourself for that, or, working with that client knowing that you have that bias?
Yeah, absolutely. Well, first off, if you just know that you can't work with people like that, like don't let that be one of your specialties, right? But if it's just something that, because everyone has bias, right? If you say you don't, you're a liar because everybody does. And the best thing is to talk it out with another provider, right? So for me, if I'm struggling with someone who's talking about how they did this horrible thing to somebody else, or how they hurt, like they hurt their body, right, because of like previous self-harm issues, right? Maybe that's something that can be a bias for me. I'm like, oh, well, you're hurting yourself or you're hurting these other people. I don't love that. I would talk to Sue, like one of my coworkers, one of my colleagues, be like, hey, I have this client who's doing this and it's a struggle for me, and talk it out with them. Usually they are able to either give me advice on how to proceed or validation, right? Be like, yeah, that makes sense. Like, of course, that's a hard situation. And oftentimes give you resources too on how best to help that person. So yeah, talking it out, right? Therapists need therapists.
Yep.
Yeah.
Thank you.
Yeah, of course. Yeah.
Yeah. To get back onto track now, the remainder of the question is: have you been aware of any recent legislative, government, and regulatory processes relevant to clinical mental health counseling, or that have impacted your practice? So, has the
Yes.
government interfered or helped with your practice? Is what I'm getting from that.
Sure. Yeah. So is there any like legislative, government, anything that has impacted my practice, my ability to provide as a therapist?
or the
100%.
or the clinical mental health field
In
overall? I
general,
mean,
in
either.
general. Yes, 100% it has. Absolutely. No question about it. Like even take the most recent presidential election. Myself, my coworkers, and many other people in the field, because I'm on lots of chats, lots of social media pages as well. There has been a huge increase of anxiety and depression among clients. There's been impacts on people within certain communities as well, right? Like immigrant communities, LGBTQ communities, people who are in federal jobs, people who receive like federal like funding or welfare, anything like that, people in education. Like there has been many effects to that point. And actually, like when you sent me these questions, I was looking to see if there was any more specific things that I could find for it. And a lot of like going to the immigrant communities, a lot of research has been indicating that the political changes during the Trump administration were associated with higher levels of chronic stress and decreased perceived mental health among immigrant populations. So different policies have created this like hostile contribution and to these people's lives, and it's increased their distress. And like I'll include this like all in our show notes, but that is one. Another one, the LGBTQ individuals. There's been both local, right, in North Dakota. We could talk about that. on like women's reproductive rights, or there's also been federal. There's been so many different ways you could look at it, but going to the concerns of LGBTQIA plus individuals, there's been executive actions that have affected like transgender rights, gender affirming care, that has absolutely led to heightened anxiety within these communities. I've even had clients debate going to Canada, going to Europe to live in Europe because they are afraid of what's going to happen to them. So it has affected my practice. I would like to say that I'm able to help them and help them cope. And at the same time, sometimes there's just things out of your control, right? And helping them to accept, okay, what's out of my control and what's in my control? What can I do to help myself and to let go of the things or just accept the things that are out of my control? And I say accept, but I don't mean agree with, right? Accepting something as it is doesn't mean you have to agree with it. It just means understanding that's not in my power, right? So yes, I absolutely have.
Yeah.
Very good question. Very good question.
Yeah, that's kind of all I have on that one. I don't know if you have any follow-up remarks or if we should move to the next question.
Yeah.
That
Yeah.
was a good answer. So
Yeah. Thank you. Well, I mean, feel free to
yeah.
add your commentary as well. Like would you say that you've noticed any changes with that or challenges with the legislative government processes?
Um, I'm I'm in a little bit of a different position than you are, since I'm still learning how this all works, and I haven't worked with anybody yet, so I haven't seen any direct impacts of it,
Mm-hmm.
and also just because of my own personal life, is I'm not very much in the loop of it because
Yeah.
all that stuff is on the news, and something my entire life, well, not most of my life now at this point, I have just realized that the news is just one whole big negative feedback loop. And so I do not have a lot of like news involvement in my life. So I'm not very up to date on things like that, which I
Mm-hmm.
acknowledge is, potentially an issue and could potentially lead to problems. But
Yeah.
I feel like since I've cut that stuff out of my life, I've felt happier and more content because
Mm-hmm.
I'm not getting all this negative coverage every single
Right.
day. And
Mm-hmm.
so, my parents watch the news, and so whenever I go home, I'll hear it on in the background, and
Mm-hmm.
I'm listening to it, and I'm like, "Oh my gosh, how can you
Yeah.
watch this stuff? It's all bad."
Mm-hmm.
So I will raise my hand that I am not very up to date
Yeah.
on any government issues regarding
Mm-hmm.
the field.
Yeah. Well, I mean, it's a double-edged sword, right? On one hand,
Mhm.
therapists, people who are providers, right? We tend to see or hear kind of the worst parts of a person's life, right? Like people don't typically come to me because life is perfect and great and they're like, I just want to share it, right? Usually it's because there's
Yeah.
some shitty stuff that's going on in their life that they want to talk about. So I understand the
Mhm.
fact of like wanting to escape some of that and get some good going on in your life. And to like providers, we do have an obligation to be informed, right? Because we don't want to ever have our clients be our primary informant. To some degree, that's totally
Yeah.
like fine and natural. And we also want to be doing our own digging and our own research. Like I know for me, a lot of where my research starts is with Instagram reels, TikTok videos, and then I
Mhm.
go I go from that and I do my own, right? So the way it starts, the information I'm getting starts is very relaxed, very different. But it's got to start somewhere, and then that gives me an opportunity to go learn more on my own. But yeah, good question.
Yeah. No, I also am kind of in a similar boat that when I do get information, it's usually through memes or some kind of,
Yeah, yeah,
ironic presentation of
yes.
whatever's happening. And so, the most iconic thing I can think of off the top of my head was the death of Queen Elizabeth. How I learned that that happened was through the meme from that one scene in Megamind where he's
Oh
like, "There is
no.
no Easter Bunny and there is no Queen of England," and then it just popped up the headline, and I'm like, "Okay, well that is one way to learn." And so it's a very ironic sense and a very ironic way to learn information. And so I'm very well aware that
Yeah.
need to, find different ways to become aware of what's going on.
Yeah.
But I agree it is our field that we get to hear the bad things about people's life, but I like to put the twist of like we're helping them work through it. And so,
Yeah.
we're not going to get them coming in being like, "Oh my gosh, my day was great," but we
Yeah.
get to
Which is
see
nice when we do.
this is
Like, it is nice.
yeah. Oh yeah. Yeah. How I imagine it is that you get to see the slow progress as somebody slowly gets better, and you get that pride, and you get that like, the joy out of that of being like, "Oh my gosh, they're getting there. They're making it work."
Yeah.
I don't know.
Yes,
Maybe you
absolutely.
have experience in that.
Yeah, well, that process is absolutely wonderful. That's kind of why I got into it, right? Is being able to see them go from like some of the lowest points of their life to slowly, gradually, like feeling way better. And like people, like you're never not going to ever get stressed again. You're never not going to feel down and depressed. Like there's no cure for anxiety or depression, but there are better ways to cope and manage, right? So seeing them
Mhm.
be able to better use those skills and to do those things is very rewarding and one of the reasons why I love this field so much. Well, what's your next question for
Sweet.
me?
All right. The next question, I'll read the whole one. It looks like there's three question marks in here, so we'll worry about that as we go. But
Okay.
here's the whole question. What are some strategies for communicating with other behavioral healthcare professionals? How do you approach consultation or discussion of client issues with other counselors and mental health professionals? And do DSM diagnoses help with this communication? So I'm sure you're aware the DSM is the Diagnostic Statistical Manual, has
Yep.
all the disorders listed and the requirements for them. Um, so I don't know if you how you want to tackle this question, but the floor is yours.
Good. Floor is yours. Okay. Well, as far as the first bit of that is of like communicating with other like healthcare professionals, I mean, I would say, be professional, be courteous when communicating with them, right? Make sure, like I said earlier, if you are exchanging client information, make sure that you have that release of information, that ROI on hand. And okay, also, like maybe this is just a personal preference, but when you are communicating, I always love it when people give me multiple options of getting back to them because I see clients every hour on the hour. So my ability to quickly call somebody for 10 minutes just is not going to work for me. So I always love it when people are
Mhm.
like, and you can reach me at my phone number, da 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 da, and my email, da 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 da, because I love to be able to just like send a quick email, right? That works better for me.
Yeah.
So a little bit of a personal preference, but yeah, professional, courteous. I think like that's something that most people would hopefully get. I don't know if your college, like if your program teaches you this, but I think it was in my bachelor's degree. They were like email etiquette, and they taught us about how to like email each other like properly. And I'm like, okay, here I am in my professional career, and I send emojis to my coworkers. So sometimes you can have some fun with it.
Yeah.
Yeah, the other part of it of how to approach consultation or discuss a client's issues with other counselors and mental health professionals. For me, I know it can be done differently at other agencies, but where I work, we have weekly individual and group consultation scheduled out for people. So this is where you can get like advice on the case, you can receive some support, validation, additional resources. So my one-on-one is with another colleague of mine, and she and I are usually able to address pretty much anything that I need to in just that 1 hour, right? Like I'll bring a case to her, we'll talk it through, she'll give me some advice, support, whatever I need. And then when you put it in the group like aspect, sometimes people like usually what we'll do is everyone will give a quick update of like how they're doing, like their week or whatever. And then they'll say, I have a case to bring up and it's either low, medium, or high priority. And then if say I have a case, I'm like, it's like medium priority. And then another person's like, it's high priority. So then we'll get to the high
Mhm.
priority one first, then we'll do mine if we have time, and then anybody else's, which I really like that system. I like being able to go to both individual and group because individual, I feel like I'm always going to get what I need out of it. Like And for group, if I don't have anything, or if I do, it's nice to provide support to other people and to get support, see how they're handling other cases. I've even had it where someone will bring up a case that I also have been struggling with, but I didn't bring it up, but like they'll bring up theirs. I'm like, oh my God, actually I have a case that's kind of similar. It's nice to hear your approach and to hear what other people have to say. So for sure, that's nice. And then the last bit was something about the DSM, like how that helps, like how that works with this.
Yeah, the question is, do DSM diagnoses help with this communication? So if you're asking for a consult,
Yeah.
does a diagnosis help with that?
Yeah. Yes, I would. Yes, I would say that the DSM, the Diagnostic Statistical Manual, can be very helpful in this process. Because if I go to just some Joe Schmo on the side of the street and I'm like, yeah, like my one person with, which I would never do because obviously confidentiality, but I'm like, yeah, my one person with BPD, borderline personality disorder, they're going to be like, well, what the fuck is that? Like, I don't know what that is. Versus my clients, I can be like, yeah, my client, Jane Doe, age 45, I diagnosed her with BPD, borderline personality disorder. And my colleagues can immediately, you know, kind of imagine the client, know the symptoms, know what's going on. So it's just more able to provide more effective treatment, you know, and also to refer back to the DSM sometimes, you know, maybe there was a misdiagnosis or there's a confusion of how to properly diagnose somebody. So it can be helpful to like go back and be like, okay, what's the criteria? What's going on? And I do really love that the DSM is updated. I believe, is it every 2 years? At least, I think that's what it is. I don't know for sure, but I do love that they update it. Do you know?
I know they might do like revisions every couple of years, but they don't usually come out with a new. I think it's every 16 years they come out with a new one. So
yes, that's what I mean. Revision. Sorry.
Yeah.
Yes.
No, you're all good. I think the 5TR, the most recent one. Well, I suppose that was updated. I think it was like 2018 was when it was updated, so it hasn't been updated for a while.
Okay.
I could be mistaken on that number.
I thought it was like 2020.
It came out. Yeah, it came out in, I think, 2012 is when DSM-5 came out.
Okay.
I think. And so we're approaching that time period when the DSM-6 is expected to be around this time. Whether that happens or not, I don't know. Maybe it's just, coincidence that it's happened.
I just looked it up. The DSM-5TR was released in 2022. So they do update it quite frequently. That's what I thought, because it was just updated right before I was like when I was in grad school. So, because I remember like everyone was so excited because you're like, we have some new, we have like a new revised version to dive into. But yeah, I always like to make this little like joke, as long as the person I'm talking to doesn't have religious trauma that I know of, that the DSM is like a therapist's Bible. So yeah, feel free to use that.
I might have to steal that.
Yeah, it's pretty good. Usually gets them laughing, especially when I have to break it out. If I want to like use it with a client, I'm like, all right, so I know this book is scary, but don't worry. I'll hold your hand through it.
Yeah.
We'll get through this. Yeah. Did you have any other questions about like that consultation aspect?
No, I can't think of any right now. Maybe if one comes up, I'll bring it up, but I can't think of anything. We can move on to the next one.
All right.
I only see one question mark, so this might actually be like a real question.
A rarity. A rarity.
Yeah. How can we, as mental health counselors, develop strategies to advocate for people with mental, behavioral, and neurodevelopmental conditions?
Okay.
So how do we advocate for our clients is kind of how I'm.
So it's one question, but it's a very complex question. So
yes.
I would say yes. Did your professor write these questions?
Yeah.
They really do love to group these questions together when it's like, oh, here's 15 questions when really it's like 30. We love it for them though. So I would say that advocacy occurs on different levels. So you can do it on like an individual level. You can do it on like, have you ever heard of, I think it's micro, meso, macro. Okay. That's what I thought. I was like, it's been a minute since I've been out of school. So they can have it happen at different levels like that. Okay, so for people who don't know what that means, micro is like the individual level. Meso is kind of like the person with their immediate people in their lives, so like maybe family, friends, right? Like work colleagues, whoever. And then macro is like their agencies that they're a part of. So like this would be like the school, or they're like, I don't know, the government, I don't know, like bigger, like think outside, right? Like a small circle getting bigger. So it can happen on an individual level. So you could do like encourage a client for self-advocacy, right? So teach clients how to express their needs in both medical, academic, or workplace settings. You could provide psychoeducation to clients on mental health rights, what available treatments there are to them, give them different coping strategies. You could support workplace school accommodations, right? So sometimes I'll have clients who come in and they're like, yeah, I really struggle to focus, or like people like will talk really loud. So I'm like, okay, let's get you an IEP, an individualized education plan, or a 504 plan, because it sounds like you could use some support, especially when you're at school, right? So that's another way to advocate. You could do like mental health awareness campaigns, right? You could partner with different agencies, your workplace, community centers, to promote more understanding for mental health, or different communities within like the aspect of mental health. You could provide trainings, workshops. You could educate other people. You could even go to the legislative level as well, right? You could advocate for laws that increase funding for mental health services, that protect different patient rights, that expand insurance coverage. There's really a lot that you could do. You could write letters to lawmakers. I've done that. I've wrote letters opposing or in favor of different laws. I've gone to like, you could go to, what are they called? Rallies. Alleys.
Rallies, yeah.
Rally in the alley. Something like that. Little joke. So that hopefully that kind of helps with advocating. Basically it just comes down to like, okay, what's the need, and what can I do within my control to help fill that need? Because even though you may not be the one to sign a bill, you can certainly do other things to advocate for the bill, as an example. Yeah.
Certainly.
Yeah. This is a very good question. Advocacy is important.
Yeah, I'm trying to think if I had anything else to ask around that, but I think you did a very well fleshed out answer for it. So,
Thank you.
yeah. I suppose we can move on to what's listed as the last question. I see 2 question marks, so we'll see how that works.
Okay.
So the whole question reads, how do you evaluate the impact that managed care has on professional practice, and how has third-party reimbursement impacted your practice and ability to diagnose? So I'm guessing that second part is asking about insurance. I don't,
Yes.
maybe there's other third-party reimbursement out there, but that seems like insurance to me.
Yeah, that entire question is about insurance, because at least for mine, I don't work with insurance. So people who do, don't come for me, please. But typically, like when you talk about like that managed care and the third party reimbursement, typically that's going to be talking about insurance. The system where insurance companies or third party payers oversee or regulate different healthcare services, including mental health treatment. So it significantly influences the way that mental health counselors, therapists, other people like provide care. It affects accessibility. It affects clinical decision making. It affects reimbursement. It also affects ethical considerations, right? So if we're talking about the accessibility aspect, like one thing it does is it increases access to care, right? So that's a good thing. It helps care to expand out to expand services to the people that are being covered for it, right? But the thing it also does that's not so great is it can restrict treatment options, right? So insurance companies will often require pre-authorization or like a good faith kind of statement. And sometimes that can mean they'll limit the number of sessions a person could have, potentially disturbing the therapeutic process, right? So if I have a client who comes in, severe case, they need to be seeing me like at least once a week, right? Usually that's the most insurance companies will do, right? Typically. Some will do more than that if it's needed. But the insurance company's like, we only cover like 12 sessions a year. I'm like, oh, that's not enough. That's not enough, right? And that really sucks for the client because then they might have to pay out of pocket costs or they just won't get the service that they need, which is not great. Another bit is like that financial reimbursement considerations. So one good thing it does is it increases like a steady client flow. So counselors who accept these managed care insurances can receive a higher volume of clients. But some things that are not so great that it does is that it can lower reimbursement rates. So insurance reimbursements can often like be lower than private pay, for example, right? Private pay rates are usually going to be that like more bang for your buck, like you're going to get more reimbursement for the service. But that taps into a whole nother issue of like commission, like working for commission. But it forces counselors to take on more clients to sustain their practice, right? So that's me. Like I receive money through like, I work salary, but the company that I work for gets paid through insurances, right? So if I'm not meeting the required client amount, which is 30 per week, I believe, 31, at minimum, then I may be at risk of being fired or being like, oh, we're going to move you to part-time since you're not meeting the required amount of people. So it certainly can create challenges that way. It can also create billing challenges. So counselors may and I don't have to do this because I don't work with insurance, but counselors may have to navigate complex insurance paperwork, authorizations, claims, all sorts of things. And that kind of leads into this decision-making, clinical decision-making, and ethical consideration, because one good thing it does is it standardizes treatment approaches. So managed care promotes the use of evidence-based treatment, such as CBT that we were talking about earlier, which can improve treatment outcomes. But a bad thing that it can do is it can reduce clinical autonomy, right? So insurance companies may dictate treatment plans requiring the therapist to justify a diagnosis or to justify an intervention. It can also pose like potential confidentiality risk, right? Because counselors sometimes have to share client records with insurance companies, which, raises ethical concerns, which is valid, but it's like, okay, otherwise, how are you going to get the care you need? So it's, again, double-edged sword. Yeah. And it can also sometimes harm the therapeutic relationship. For me, I'm fortunate. I can just send a client off to our insurance team and they can like help them. But if I was working in a clinic where I also have to do insurance, I would have to be both the bad cop and good cop. Be like, oh, hey, I just helped you with your trauma. That's cool. By the way, here's this bill that's overdue. That would suck. That would really hurt the relationship. The impact of managed care on mental health counseling is that double-edged sword. While it improves affordability and access to care, it also restricts the clinical autonomy, reimbursement rates, administrative burdens, all those things. And the counselor has to balance working with the system while also advocating for the client. So it can be that tricky, like, where's the balance sort of thing. Okay, I want to make sure I hit the other bit of that question was like how third-party reimbursement can impact your ability to diagnose.
Yes.
Okay, before I move on, sorry, I don't want to just like jump to it. Did you have any questions on that other stuff I was talking about?
I think the only thing that was kind of standing out to me, and this is something we've discussed in class, and you kind of touched on it a little bit, is insurance companies like those evidence-based models, CBT being one of the primary ones. I know that this is one of the critiques of CBT though too, is that since it's so evidence-based, that's the one that all the insurance companies go to. So it gets all of the limelight, whereas some of these other strategies or techniques maybe are just as effective, but they're not getting any of the research funding for. Do you have any
Right.
thoughts on that?
Yeah, absolutely. 100%. I mean, because, CBT, and that's kind of what I was saying earlier, how it can be nice because it can work comorbid with other modalities, other interventions. So sometimes like what I might do is I'll say like, yeah, like I use CBT. I also used exposure therapy or narrative exposure therapy as well. But like the insurance companies can be like, oh, I see CBT. Great. But I also use this other one too. So sometimes there are ways to kind of go around it and be like, oh, I'm also using this. When it comes to funding, I wouldn't say I know too much about that aspect of funding for the different modalities and interventions. some interventions may require more, like maybe materials, right? Have you ever heard of EMDR before, right? Like the eye movement
Yep.
desensitization. Yep.
Yep.
That requires supplies, right? You need the things. You need like the laser. Maybe you need headphones. You might need something like tactical that a person can use.
Yep.
Different equipment, right? So like, where's the funding for that? That is, and EMDR has been around for a long, long time, but it's maybe just not quite as popular or quite as common because the focus isn't put as much onto that compared to something like CBT. So yeah, very good question. Okay. So how the third party reimbursement impacts my practice and my ability to diagnose. So some challenges and, considerations to think of are like the insurance restrictions, the diagnosis requirements, reimbursement rates, like lower reimbursement rates, and confidentiality concerns, all those things I was talking about before. So some plans limit the number of sessions or required pre-authorization. So that can be a challenge to consider as far as how it can restrict, and that can sometimes happen for me. Like, for example, I might have a family or a couple who was approved through their insurance company to see me for couples therapy, aka family therapy, because you actually can't bill for couples therapy. If you didn't know, you can only bill for family or individual. But say one of the people, I mean, I would never do this because of other reasons, but say one of the people, the individuals in the couple came to see me and I had the session and then sent them on their way. And then the next week I was going to do couples. Their insurance could deny that individual session because they were only pre-approved for family therapy. So like that can pose, risk to me. Luckily, I'm not working on commission, so I don't get paid for the billable sessions. I get paid salary. So if that were to happen, it doesn't really hurt me, but it hurts other people, right? It can affect other people. So that can be a challenge. Yeah. Many third-party payers also require formal mental health diagnosis for reimbursement. So, I mean, that's just a thing that is always needed. Like you have to have a diagnosis to be able to bill, right? Like you can't just bill nothing. You need to bill like major depressive disorder, generalized anxiety, like PTSD, and some diagnoses are more acceptable than others. And I'm doing air quotes for insurances. It just depends. It can lower reimbursement rates. So insurance often pays less than private rates, impacting a provider's income. Confidentiality concerns, right? Insurance companies may require detailed treatment records to like authenticate what the treatment plan is or the diagnosis is of the client. But that again can affect a client's privacy, right? They have a right to be private. Like they shouldn't have to tell these insurance companies like, yeah, this was my trauma from growing up, but here you are.
Yeah.
But yeah, like I said, I personally don't work with insurance companies, so I'm very fortunate that I do not have to deal with that side of my career field. And I get to just put all my focus to my clients and how I can best support them, which is where I really thrive. Right. I mean, I think most people would agree that there's always going to be some aspect of your job that isn't the thing you most love, right? Like I didn't go in to be a therapist because I absolutely love documenting and I absolutely love writing up like different progress notes. I don't mind it, but I became a therapist because I love working with people and I love helping them and I love, working with them and enabling them to do what they can, right? I never want to do it for them and I never want to be the dictator of their life. They are the person driving this ship. I'm just helping them steer. So yeah. Very good question. Any final questions that you had for me?
I think I've got one in reference to insurance and
Yeah.
diagnoses. Do you think that the requirement from insurance companies to have a diagnosis leads to either inaccurate or over diagnoses? So like, do you think that maybe, this is borderlining on unethical practice.
Yep. Yeah.
But it seems like it might be something that happens like if somebody is struggling and they need help, and the insurance isn't going to cover it unless you give them a diagnosis. Do you think
Right.
that happens? So what are your thoughts on that?
Yes, I do. And okay, it's different for the state that you're in, right? So
Yes.
I
Okay.
did my internship in Minnesota and now I'm working in North Dakota, but I'm licensed in both states. So when you're doing like a DA, which is a diagnostic assessment for a client, I believe in Minnesota, you have to have it done, and they just changed it within the past like year or two. So look this up. Don't quote me exactly on it, But let's just say,
Yeah.
for example, Minnesota's is you have to have your DA done within within 2 days after meeting with the client, right? And how are you supposed to properly diagnose a person after one session?
Yeah. You're
For some
not.
people, for some people it might be more obvious, or maybe they had a previous diagnosis. So it's not always an issue, but it can be an issue, right? Especially if this person's getting care for the first time. So sometimes people will like just put a diagnosis in that they believe like with the information they have is like what they would give. But then later down the road, they may be like, oh, you know what? Actually, like we're going to rule this out and it's actually this diagnosis. So it can lead to misdiagnosis, but that's just because like insurance requires, like the state requires you have to have it done within 48 hours, right? Versus maybe somewhere like North Dakota, we have to have it done within 24 hours, right? So we have to have it done even quicker. So it can be challenging, again, for the same reasons, but you can just rule it out later, right? You can just be like, oh, we'll rule this out, right? If a client were to say like, oh, I'm also looking to get medication after this diagnosis, I might be like, okay, can we hold off? Let's have at least a few sessions under our belt so I make sure I'm confident in my assessment before I diagnose you. Yeah. So yeah, good question.
Cool. Thank you.
Yeah, of course. Did you have any other like final questions at all?
I don't think so.
Okay.
That was all that was listed, and I mean,
Yeah.
I did a couple sideline questions in the middle of
Love
it.
it.
So
Great. Are you able to share like what's going to happen now after this? Like, do you write a paper for this? Do you present it to somebody?
so I believe how the assignment is laid out is, done the interview, and then I'll write a paper about it. I think it's 4 or 5 pages, so that actually might be there's a lot of content that's been covered, so it might be a struggle
Yeah.
to limit it to 4 or 5 pages. So
Yes.
that's good. That's good. Thank you.
Yes. Yeah. I guess it's better to
Um,
have too much information than too little. But yeah.
yeah. Yep.
Okay.
So
So paper.
I'd rather do video essay or something, but assignments are assignments.
Right. You could have just handed this in, right? Be like, here we go,
Yeah.
professor. Yeah. So you told your professor that you were going to put it on a podcast. Did he have a reaction to that at
Yeah.
all?
His first reaction was he thought it was going to be like my own podcast, and he's like, "Well, you're going to have a disclosure and a consent to record and stuff like that." And I'm like, "Sorry, I said this wrong. This is for somebody else's. She already has that, and she's already providing it." And so he's like, "Okay, then you're good to go. Just maintain a professional
Yeah.
appearance, and
As I'm like
because you're
swearing in
representing the
this.
school." Yeah, it's all good.
Well,
'Cause
you were
was saying-
great.
thank you.
Yes. Yes.
So.
Well, if your professor's listening to this, like, just know that like Josh did great. You did awesome. And I really appreciate your time today. And like, this is it's a little odd because like you interviewed me, but I do appreciate it. Like you came to me with this, and I was very honored when you came to me. You're like, hey, I want to do this interview. I don't know if I'm just the only therapist, or if you genuinely were like, Grace. But either way.
You were one of the first ones to come to mind, and I was like, I know I have the connection. We used to work at a restaurant together.
Yeah.
I'm good friends with your boyfriend. I'm like, this just makes sense. I'll see if this works out. If this doesn't, we'll figure it out later. But
Yes.
thank you for your time. I do appreciate you helping me out with this.
Of course. Yeah. I was happy to do it. And then I was even more ecstatic when you agreed to like, let's put it on the podcast. All right. Well, thanks for your time. If you liked what you heard today, or if you have more questions, you can reach out to me at life.motion24@gmail.com. My Instagram is life.in.motion24. My TikTok is life_in_motion24. Leave a review, leave 5 stars. If not 5, then don't leave any. I'm just kidding. Share with your people, and you can watch this, or you can listen to it, watch it on Spotify, Apple Podcasts, YouTube. But stay tuned in to hear more all about life in motion. Until next week, embrace the chaos and find the beauty. Bye.